guy in the back. Good morning. Can you hear me in the back? Okay, great. Thanks, Cole. It's my pleasure to introduce today's speaker, Dr. Andrea Matsumura. Dr. Matsumura graduated from the University of Texas Medical School in San Antonio and completed her internship and residency here at Prov Portland, finished in 2002. She practiced internal medicine for 12 years at Kaiser before she went on to complete her fellowship in sleep medicine at OHSU, and she's currently practicing at the Oregon Clinic. Today she's going to be talking to us about I can't sleep, I can't snore, I'm tired, common sleep disorders in primary care. Thank you.
Morning, everybody. So a couple of things. This is awesome that there's a platform for me to stand on. Is my mic on? No. Oh, it is? Can you hear me now? Do I need to slide it up? Okay. I was just saying that we found this platform for me to stand on so that you could actually see my face while I'm talking this morning. And then the other thing is, I see a few people wearing red today. Who's wearing red? Yay. It's International Women's Day. So we adopted this day actually from Russia. In 1917, women went to the capital of Russia and they were upset about, obviously, women's inequality, rights, all that kind of stuff. We adopted it in 1977, this particular day. So I just want to give a shout out to all my fellow women providers who are out there in the audience today. Yay. All right, so today I'm going to talk about common disorders in sleep medicine. It's a really big topic, and I thought to myself, what did I get myself into? Because there's just so much to talk about. So I'm going to try and get through as much as I can. And I'm going to really focus it on what I often hear, which is somebody can't sleep. They have insomnia. And a lot of times we're trying to figure out ways to screen folks, and it's difficult to predict who is actually going to have sleep apnea and who doesn't have sleep apnea. But what I find, and a lot of our questionnaires are really focused around daytime sleepiness and how people are functioning. But what happens mostly is that people don't come and say, gosh, I'm so sleepy. They come and say, I can't sleep. I either can't get to sleep or I can't stay asleep. And I like to kind of put it in these big 4 buckets. One is sleep disordered breathing, which we're going to be talking a lot about. The other one is circadian rhythm disorders and sleep hygiene. We live in a chronically sleep-deprived society right now because we all have phones that we put and take to. How many of us take them to the bedroom? How many are guilty of that? And how many tell your kids or your other people, don't take them to the bedroom, and then you're sneaking them into the bedroom with you, right? So we'll talk a little bit about that. And then movement disorders. So restless leg syndrome, that's often difficult for people, have difficulty getting to sleep, or it can wake them up and then they can't get to sleep. And then chronic insomnia. So we'll go over that. So just a little bit about what we look for, or what we're looking at as a sleep medicine doc. We're taking a look. This is a hypnogram, which just basically shows you the different stages of sleep. So there's stage N1, N2, N3, and then REM sleep. And really the goal is to get all the stages of sleep. It's not, people will say, I never dream. You do not have to remember your dreams to know that you actually had REM sleep. So that's just a little tiny overview of what we're trying to look for. And the longer your sleep time is, the longer your stages of REM should be. And they're usually happening as we get older in the second half of your sleep. So is sleep neuroprotective? So it's been this big question, like, why is it that we sleep? Why do we have to get to sleep? What is it doing for us? What we do know is that it hinders our memory recall if we do not get enough sleep. We're slower to get things done. We're not as efficient. We have what are called micro sleeps. So one of the most common reasons why people are actually in car accidents or there's big accidents that we've heard about in history is because they're having these micro sleeps. You don't even know it. So what I tell patients is it's similar to somebody looking down to read their text message. You don't realize in that split second that you fell asleep, and then you're crashing into somebody or you're crashing into a wall. So I've had people who've come in to see me and they didn't even realize it. They're drivers and they find themselves crashed into the side of a building. So the other piece is that it can obviously elevate stress levels. How many of us here on little to no sleep feel like, you know, your nerves are just a little short that day when you don't get enough rest? And then the other piece here that's really important is that, you know, we're working all day. Our brains are working all day long, and it builds up waste. And there is this system that is similar to the lymphatic system of our body. It's called glymphatic system, and it's basically made out of glial cells, and it's thought to increase the cerebral spinal fluid when we're sleeping and kind of be the garbage disposal for our brain and clean out all the waste so that we then have this clean slate in the morning to start with. This is just a really quick graphic on sleep homeostasis. All this is showing you is that in the morning when we wake up, our drive to sleep is low and our circadian wake drive is high. That's kind of logical. And then as the day progresses, our sleep pressure or drive to sleep increases and our circadian wake drive diminishes. And this is important when you're talking with patients and they say, I'm so tired, but I'm taking these big long naps during the day. They're diminishing their sleep pressure, their ability to build that sleep pressure during the day. So instead of it kind of increasing as the day goes on, it'll increase and then diminish because they took a nap. Then increase, diminish. So then they go to sleep, you know, it's nighttime and they want to get their full time of sleep and they can't because they diminish some of that sleep pressure during the day. So I'm going to focus on that one initial piece, the insomnia, and then we'll kind of separate it out. But this is based on the International Classification of Sleep Disorders, version 3, which is kind of the book that talks about all the different types of sleep disorders and the criteria. And so basically it's what I've already discussed, which is either falling asleep, staying asleep, maintaining a good consolidated sleep and feeling refreshed or having restorative sleep so that when you wake up you feel good. The big piece is what patients come in and they say, I feel fatigue during the day, I'm tired, and it's important to kind of try to distinguish the difference between fatigue and sleepiness. So some people, they can feel fatigued. That's different than saying, I am just so sleepy, I can fall asleep anywhere. The minute I sit down in a quiet room, I'm sleepy. That's different than just saying, I just feel fatigued. The other pieces here are like attention, concentration, memory impairment, your performance. People sometimes are struggling at work, especially if they've got to look at a computer or they're doing a lot of computations, things that are a little bit more mundane. They'll say, I'm having a lot of trouble concentrating. I have to do things over and over again. And then obviously people who are suffering from any type of anxiety or depression, it's going to be much more difficult to feel like that's controlled. They're going to be have a shorter trigger for those kinds of things happening where depression and anxiety can really affect their life. So short-term insomnia, really quickly, it's 3 months or less. It's usually happening from some sort of event in your life, and that can be positive or negative. You just had a baby. You just got this great new job. You just moved across the country. Somebody died. You got a divorce. It can be any big life event. Also surgery. Sometimes we don't think about that, but when people come into the hospital, because we see them all the time, and it's nothing kind of, to us, this is our job. To them, it's a gigantic big deal. And sometimes surgery can then tip off and start this cycle of insomnia. Jet lag. People who do a lot of traveling can have some insomnia, and that can either be short-term or long-term depending on what kind of job they have. And then pain. That's another piece that's often overlooked. People who suffer from chronic pain, they'll have a difficult time getting to sleep and staying asleep because of pain. And we understand that and realize that when people have, again, had a surgery or a procedure, there's an acute period, but sometimes it's then long-lasting. So those are the things that we need to think about. Chronic insomnia, it's longer than 3 months, and it's at least 3 times a week. And so that's the big difference. Shorter than 3 months, longer, or over 3 months, and it's happening at least around half of the days of the week. And that's just also, you have trouble getting to sleep, or when you wake up, it's taking you a long time to get back to sleep. So I'm going to kind of move into, now we're talking about, we talked about insomnia, and then that first piece, which is sleep disordered breathing. And this is Pinky. She is a service dog, and sometimes, how many people have had service dogs come and visit them with their patients, right? Exactly. And sometimes you don't know who you're treating. So I'm going to, I just want to play this because this person that came in for a consultation, their dog came with them, and it was pretty impressive. So that's an apnea right there, okay? So the whole time I'm talking to this lady, severe apnea by history, and then I'm just watching her dog the whole time. So yeah, during that visit, this person had a sleep study ordered for them, and then also got a really great referral to a local veterinarian. So. All right, so sleep disordered breathing. There's 3 types, basically, obstructive, central, hypoventilation. And basically, it's airway obstruction during sleep. And, stereotypically, it's when it's the guy who's doing all the snoring, the wife doesn't want to sleep in the same bed, or they're constantly, telling them to move over. Not so much in women, so that's kind of something to think about. In women, it's not, women hardly ever are coming in saying, oh, I snore so loudly, or, my spouse doesn't want to sleep with me. But though women tend to have more fragmented sleep, they might have more symptoms of depression, and they don't complain so much about their time of sleep as much as their inability to stay asleep or the constant fragmentation of sleep. Because I think part of the relationship for a lot of women that I'm seeing is that they were the ones who are getting up with kids, or they're the ones who have more fragmented sleep, and now the time where they can actually sleep through the night, they're not. That's kind of a tip-off. But again, common symptoms: snoring, witnessed apneas. Also, when people say, I wake up with a dry mouth, sometimes I have voice hoarseness in the morning, and I just feel sleepy during the day. And then other associated symptoms, having to change position on your back, that's when it's worse. People often say, when I move to my side, I don't snore as much. Nocturia, getting up in the middle of the night to go to the bathroom is a really big sign, not just an enlarging prostate. It's a big sign that something might be going on. And then atrial fibrillation. Oftentimes, we'll see a person who might have some irregularity in their rhythm when they're having the apnea. And so one of the other tip-offs is, do you ever wake up in the middle of the night with your heart racing? And that's a tip-off that they might be having some sleep-disordered breathing during the night. Reflux, it's worse with sleep apnea. Headaches, that you can wake up in the morning with headaches that often kind of wear off. Teeth grinding, and then also long-term use of narcotics. Those folks have an increased risk for central apnea. So if they already have snoring, they already have other symptoms, and then they're on narcotics, it's kind of a double whammy, because they may not only have obstructive, they might have some centrals as well. So this is the severity score for obstructive sleep apnea. Mild, 5 to 14, moderate, 15 to 29, and severe 30 plus. So that means they're having, if you're severe, that means you're having 30 events or more an hour. That's a lot. That's every other minute in an hour. So that's how I describe it to patients, because they'll say, well, that's not that bad. And I'm thinking, you know, every other minute your brain is telling your body to breathe. That's kind of a lot. You're not getting any really good sleep. So why is this important? There's about 26% of adults between the ages of 30 and 70. That's a lot of people that probably have sleep apnea. And why should we be treating this? Well, studies are showing that there's reduced white matter in untreated obstructive sleep apnea. There's changes in cognition, changes in mood. You can also reduce your post-operative complications. Why is it? That's why it's so important when people are going in for major surgeries, because it really changes their course. And then, as I had said, there's a high incidence of nocturnal cardiac arrhythmias in patients with severe obstructive sleep apnea. Not to mention all these other daytime symptoms where people sometimes will feel like, you know, socially they don't want to do something because they're more tired. They're having trouble at work or their personal life because of their lack of sleep. So sometimes I think when people are coming in and they think that they're these depressive symptoms, there may be something more to that. So this isn't a really clear slide. I couldn't get it to focus really well. But basically what this is showing is the cardiovascular changes that occur. And so when we're sleeping, we should have decreased sympathetic activity, heart rate, blood pressure. All that should be decreasing, an increase in parasympathetic activity. But when you have sleep apnea, how I often describe it to patients is that your heart and lungs are basically kind of running a marathon in your sleep. They're working hard the whole time trying to help you exchange oxygen and breathe. So that then leads to this chronic inflammation, oxidative stress, endothelial dysfunction, and you end up with hypertension, heart failure, heart attacks. That's a big deal. So I just want to kind of briefly touch on this article that recently was published, and it was the goal of this this article was to issue some sort of recommendation on how we should actually be screening for asymptomatic adults. And there was no good conclusion. All of these questionnaires, as I stated earlier, they really aren't that great predictors in determining whether or not somebody truly has sleep apnea. But the whole piece to this is, why are we looking for something to screen people with? And that's because when people have severe sleep apnea, it is associated with increased all-cause mortality. So that's again a big deal. Strokes, heart attacks, those are really big deals, and that's what happens when people have untreated sleep apnea that's severe. So again, we not only have those cardiac events, but diabetes, the heart rhythm problems, and then of course the increase in motor vehicle accidents. Just to kind of summarize again, when people come in and they're talking with you and they're wondering, why should I get this treated? Why do I have to wear this device? Why is this so important? And it's because of this. So again, those with high blood pressure, 30% will have sleep apnea. Those with sleep apnea, 50% have a change of, they go on to have high blood pressure if they don't already. Those who are status post-ablation for atrial fibrillation are 25% more likely to have it return. And then again, up to 70% of those admitted for symptoms related to coronary artery disease are found to have sleep apnea. I'm sure many of us have kind of seen that with patients who have had an MI, and then we realize, well, they probably had untreated sleep apnea. So again, this is just another graphic, another way to talk, to describe to you why it's so important to kind of get this evaluated and potentially treated. So I think I've talked it to death about why we have to figure out whether or not people have sleep apnea. And so now you get the results back. You see that they have moderate or severe sleep apnea. You say, oh, okay, we got to start you on a CPAP machine. And then this is kind of what patients are thinking when they think, I have to use this machine. So now what? The big thing here is I usually tell patients I really like prescribing this because it's air. But air is not as easy to prescribe as one would think because there are a lot of potential barriers. Sometimes the prescription for the machine, maybe we need to adjust it. There's a lot of basically the user limitations to this. So is the mask not on correctly? I mean, I don't know how many patients I've had over the time that I've been seeing patients who I ask them to put their mask on. That is like one of the most interesting things to watch because sometimes it's backwards, sometimes it's upside down. I mean, and then they wonder why they don't feel better or why the air is blowing in the wrong direction. So it's really important for patients to really understand and realize how to don this interface, don the mask, and how often they need to actually exchange it. There's some people who will come in and it looks like their mask is gonna walk off because they haven't actually changed the cushion or cleaned it. So the durable medical equipment companies will typically give people a schedule on when they're supposed to exchange the mask, exchange the cushion, the tubing, filters, all that kind of stuff, but hardly anybody ever is really thinking about that because there's so much information that's just thrown at them when they're given this machine and said, okay, hey, you have to use it every single night and all night and every time you sleep because sleep apnea is every time you sleep. It's not just nighttime sleep apnea. So that's really important. Also, I've had a couple of patients who will say, well, I didn't want to use it because my cats, they like to sleep right next to my head and they don't like the air blowing in their face. And I mean, it's like, so there's all kinds of potential barriers to using this mask. And there isn't a whole lot of research on how we can help patients and educate them to improve compliance. So that's the biggest thing here. But as most of us know, and if you don't know, the requirements are at least using it 4 hours for 70% of the days. So that's really important to remember. And when patients come in and they tell you that something's going on with their machine, figure out whether or not it is actually the mechanical pieces or whether or not they're just not getting enough air and they seem to be using it correctly. Because if they seem to be using it correctly, the mask is fitting pretty well, they don't need another sleep study. They do need another sleep study, excuse me. If the mask is fitting well and they're using it correctly, then they may need another sleep study. But most of the time, it's because they either need to replace their mask or it's not sitting on their face correctly, or they might just need a simple adjustment in the pressure. But they don't need another sleep study if there's something going on with the mask or they need new supplies. So when should you consider a referral or a repeat sleep test? And that's when there's a clinical change in the patient. So if they have a change in their ejection fraction, they have pulmonary hypertension now, they've got changes in their neuromuscular capacities, so ALS patients, muscular dystrophy, multiple sclerosis, all those patients definitely would need a sleep study. If they have sufficient use, but they still complain of daytime sleepiness, so you take a look at a patient's download and they're using it the whole night that they're sleeping, it doesn't look like there's a leak, the mask fits well, yeah, they need another sleep study potentially to figure out maybe there's something going on. When they have a change in weight. So I'll have a lot of patients come in who had lost weight and then they stopped using the machine because they didn't feel like they were snoring, they didn't feel like they needed it, but then they slowly gain weight back and then now they are having symptoms again. Ideally, when patients hit their ideal weight, whatever that might be, maybe their goal is to lose 30 pounds, 40 pounds, 20 pounds, if they're losing 10% or more of their total body weight, they should actually really have a repeat study, because we've all seen those patients who are of normal weight, but because of anatomically how they're built, they still end up having sleep apnea. So it's really important that even though they may not be having those obvious symptoms, they still might have sleep apnea, and they still might need to treat it. Shift work or jet lag issues, that would be an opportunity to potentially have them go to a consult, because sometimes people have a really difficult time really kind of tightening up their daytime sleep if they're nighttime workers and they're not night owls. If people have parasomnias, so night eating, if they're doing things in their sleep and their spouse is saying, you know, you're reenacting dreams or you're walking around, those things really need an evaluation. And then legally blind patients who have sleep issues, because they can have what's called a non-24-hour clock. So our circadian rhythm for wake and sleep is a lot of it is based on light. And if you're blind, you're not getting that signal. So then there are things that we can do to help them kind of develop more of a pattern for sleep and wake. So again, long-term follow-up, if somebody's doing pretty well, they only need to be followed up once a year, but please do remind people that they need to make sure that they're replacing their equipment and supplies. And then again, anytime there's a clinical change. So I'm going to move on to that second bucket, which is circadian sleep-wake rhythm disorders. And these are the big 4 different disorders. There's advanced sleep phase, which is that early bird. These are folks who they're shutting down at 9. They got to go to bed, and they would prefer to get up like at 3 or 4. Then there's the delayed sleep person. That's the night owl. Typically, that's somebody who wants to go to sleep after 12 o'clock. And that's not really compatible with a lot of our work schedules because you got to get up at 6, 7, and if they're going to bed at 2 o'clock and they should be sleeping until 10 to get their 8 hours, it's impairing for them. And then the non-24-hour, which is, I kind of talked about that already, which is, that is typically people who are blind. And then irregular sleep-wake, those are our elderly patients, those sundowning people. They don't know when daytime and nighttime is, and they're doing these little chunks of naps all day long, and they're not really getting a good, big, one solid chunk of sleep. And that can become impairing for people. So that's the last one there. And I'm going to focus on delayed sleep, because I think this is where I will see a lot of folks who've been placed on sleep aids, and they actually have delayed sleep phase. So this is another big piece here. People, again, that's why I like to start off with the insomnia. I can't sleep. Because many people, I was, again, a primary care doc for 12 years, and a lot of people at the very end of the appointment where you're thinking, oh, I'm done, we're ready, I got to get to the next patient. They go, oh, yeah, I'm having a lot of trouble sleeping. I never sleep more than 4 hours. And you're like, okay, well, let me just write you this whole prescription, and it'll all get taken care of. It doesn't. So our circadian sleep drive is so strong in our brain that no matter what we give a patient, it really doesn't change that drive, that delayed sleep phase. So there are ways that we can adjust it. My personal preference is using light therapy in the morning and then melatonin at night. And I'll talk about melatonin because before I even say that word to patients, because they've already tried it, I'll say we're not using it to induce sleep, we're using it to change your clock. So it actually works as a chronobiotic, and I'll talk about that in a little bit. But a lot of people are affected by this, and so I think I know for myself, I completely, miss this whenever, as a primary care doc. I was given prescriptions out for sleep aids, trazodone or Ambien, or, there's newer ones, Sonata, Lunesta, all these other medications. But I would totally miss this, and not because it takes a little bit of time to kind of figure out, does this person actually have a delayed sleep phase? And should we be doing something else with them? But the other piece here is like shift work, and then delayed sleep phase syndrome. So shift workers, sometimes people who work like a swing shift or night shift, they do pretty well if they're delayed sleepers. And when people come in to see me, and they're having a difficult time because they've got this new job that's 8 to 5, I'll ask them, was there ever a time when you were working a night shift or a swing shift? And they'll say, oh yeah, that works so much better for me. And that's a tip-off that, oh, they may be a delayed sleeper. But there are ways to be able to kind of advance somebody's clock when they're delayed sleepers, and that's using melatonin and light therapy. So just briefly, kind of what I've already described, how light, it's more complicated than we think, but it basically will either, it inhibits melatonin production, and then darkness will then excite it or stimulate melatonin production. So a little bit about melatonin. Dim light melatonin onset happens at around 8 p.m. And as you can see from the graph, it starts to rise, it peaks at around 3, and then it's diminished when we're waking up. So in a patient who has delayed sleep phase, their curve is shifted. So they have the same curve, it's just shifted. So that's why we want to try and advance it and pull it back so that it's compatible with their work life or school life or their family life. And the other piece here is that they'll have this subjective sleepiness in the morning, and then they finally say that they kind of get going later on, or they catch that second wind, and they're much more active later on in the evening. But during the morning, like the whole morning time, the first 6 hours that they're awake, they often will say that they're just dragging. So one of the ways that I use melatonin is for this. It's, again, not an herbal medication, and there's all these kinds of doses that are out there and all these types of formulations. I would be really careful, and lots of patients have tried this, and they try to use it to actually help them get to sleep. And so they're not using it correctly because it's not going to work that way. You want to actually use it to help advance your cycle, and so I will often have them use it a couple of hours before they actually, their ideal sleep time, and try and advance their clock back. And you don't need a whole lot. You only need 0.5 to 1. I had one patient who was using 40 milligrams a night to help them get to sleep, and that's crazy. And then they had daytime sleepiness, because it can definitely cause some daytime sleepiness. And also be careful what brand you buy. I tell patients that. I think the Walgreens brand, not to bash Walgreens, but I think that it's probably antihistamine and it's not really melatonin. So you want to be careful what kind of brand you buy. What I tell patients is, if you're going to New Seasons or you're going to Whole Foods, the naturopathic pharmacists there, what they kind of sell there, that's probably safe. That's probably what I would focus on. But be careful where you're buying it, and then how much. You don't need a whole lot, and you don't need anything else added in it. You only need melatonin. So I'm going to move on to, I'm going to go back to that actually, because to the delayed sleep phase, because the other thing I wanted to bring up is sleep hygiene, and I'll talk a little bit more about that with chronic insomnia. But the other piece with people who have delayed sleep phase, or generally in people who have insomnia, is that they have really poor sleep hygiene. Does anybody know what sleep hygiene really means or what that describes? Kind of show of hands, yeah? Okay, so I have trouble following sleep hygiene at times. I'm sure that patients do as well. But a lot of times we're driving our insomnia and we're not actually helping our bodies prepare for sleep because we're really stimulating our brains too late in the day, and then it's hard for us to kind of wind down and get to sleep. So one of the things that I will tell patients is, how do you feel when you go camping? You know, and a lot of patients will say they feel better because obviously they're going to sleep when the sun is down. They're not staying awake because you generally don't have reception. You know, there's not other things distracting you from sleep. And so they'll say, oh yeah, I feel really good when I go camping. I go to sleep like at around, 10:30, get up, when the sun's up. That's, again, another tip-off. You're pushing yourself to stay awake later than what you actually need to. How many people here got 7 hours or more of sleep last night? That's pretty good. Okay, so I'm going to move on to restless leg syndrome and periodic limb movement disorder. So restless leg syndrome is a conscious phenomenon. That's how I describe it to patients. And periodic limb movement disorder is unconscious. So restless leg syndrome, it's that urge to move your legs. It's usually happening when people are at rest or when they're going to bed. And it's typically worse in the evenings or at night. And movement will help relieve it, but then it builds right back up. And so sometimes it can be a little bit difficult to kind of differentiate between this and neuropathy or sciatic pain. You kind of don't know what's happening sometimes. But the biggest piece here is that neuropathy and sciatic pain, they don't go away when you get up and walk around or you stretch your legs typically. Those are constant. With restless leg syndrome, it actually does resolve and then it builds up. And the other piece that's important is that you have to kind of figure out when it actually is starting. So it's not always when people are getting into bed. So for some people, they sit down, they start watching television at 7 or 8, and then it starts. So that's important because you want to, if you're going to give people a medication for this, you want to give them the medication when it actually starts at that time, not at bedtime. So if somebody has restless leg syndrome and it's starting at 7 or 8, you want to give it at least an hour before their initial symptoms start. And they may need a second dose at bedtime. But I'll have a lot of patients who will come in and they'll take this medication at bedtime, but their symptoms start at 3 hours beforehand. So that's just important to know when the symptoms actually start. Periodic limb movement, that is movement that's happening when they're asleep. And we will see that on a sleep study. We'll see leg movements, and then we'll see an arousal. And so that's different than restless leg. And for a lot of people, it doesn't really affect them, and that's something that really should be kind of managed by a sleep medicine person, because the periodic leg movement oftentimes has no effect on a patient's sleep because they don't even know that they're doing it. It's happening in their sleep. The only time I would even consider even managing that with any medication is when they absolutely have no sleep apnea, they've got great sleep hygiene, they're sleeping all through the night, but they're waking themselves up with movements. So it's different than restless leg syndrome. So again, treatments for RLS, in terms of the guidelines that are out there, ferritin, checking your iron stores and ferritin levels, that's good if somebody is actually low in their iron stores. We don't exactly understand or know how we have this central nervous system deficiency in iron, But if we replace it because the ferritin levels are low, I've had some patients say, yeah, it helped my symptoms right away. And a lot of patients that end up having these symptoms, it's like right out of surgery where they had a change in their total, in their blood count. Maybe they had some blood loss, or women who've had, trouble with managing their menstrual cycles, and they become anemic because of that. And then they end up having restless leg syndrome. So if we do iron replacement, that can be helpful, but that's often not the only thing that ends up needing to be used for patients. In some patients, yes, but not in every patient. So I just wanted to kind of touch on that really briefly, that it might not be the only thing that you need to do. And then the goal ferritin, you want to check it like 3 to 4 months later, and you want to replace the iron once a day with vitamin C, and you want to make sure that the ferritin level is greater than 75. So even though the normal is 50 and up for restless leg syndrome, there are a couple of studies showing that a little bit higher than the norm cutoff is what's needed to resolve some of the symptoms. So I'm going to go back to that chronic insomnia and how it's treated, because a lot of people will have more than one sleep disorder. They will have sleep apnea, and a lot of times we're hopeful that maybe treating the sleep apnea will then correct the fragmented sleep or their chronic insomnia, but sometimes it's two separate things that are happening. And a lot of times I will see patients who come in and they've got underlying anxiety and depression, and if that is not treated, the insomnia is never going to get better. It doesn't matter what I do or what I say or how many handouts on sleep hygiene and stimulus control I give them. It's not going to get any better unless they actually get that treated. So the guidelines suggest these other things to help with chronic insomnia, which is relaxation training, which is kind of that whole tensing and relaxation of your body. Stimulus control, which is making sure that you only go to your bed when you're sleepy. You don't spend time in your bed when you're awake. Sleep restriction, making sure that you're as soon as if you wake up and you can't get back to sleep, to just start your day, because then naturally you'll build up sleep pressure, and over time you'll extend the amount of sleep you need at night. And then cognitive behavioral therapy for insomnia. That's really the most successful treatment that there is out there, and that really kind of hits home in terms of addressing the patient's kind of false sense of perception on how much sleep they think they're getting, how much sleep that maybe they need. Because I've had some patients who are getting 6 to 7 hours, but they're thinking, I need 9, and they still feel like they have insomnia. So cognitive behavioral therapy is actually what works the best, and the coverage for that is spotty with insurance companies, but there's some really good books that are out there. There's apps. There's an app called Shut-Eye, and then there's an app by the VA. I can't remember. I'm blanking on the name of that app, but that one is free, and it's a program that people can use on their phone to help them it's kind of their own cognitive behavioral therapy coach on their iPhone to help them. And then again, the sleep hygiene piece, making sure you're not downing, 2 cups of coffee 2 hours before you go to bed, that you're not doing a lot of stimulating activity, and that people are actually preparing themselves for sleep. Let's see. And then kind of touching on medications for insomnia, as I've said before, it's really only good for short-term insomnia. It really doesn't help people with chronic insomnia. I'll have patients come in and they'll say, I take these 3 things to help me get to sleep, and then I'll ask them how long it takes them to get to sleep, and they'll say, oh, it took me an hour and a half. Well, those things are not working then if it's taking you still an hour and a half to help you get to sleep. Sleep aids should be working within 30 minutes or less. If they're not working within 30 minutes, they're not really helping that person get any more sleep. And then there's all these other medications that we all are familiar with, the herbal supplements that are out there like valerian root. Again, talked about melatonin, antihistamines, antidepressants, melatonin agonists, benzodiazepines, and then the sedative hypnotics. I got a great story about the sedative hypnotics Ambien. I had this one patient who came in. I had been prescribing Ambien for about a year, and she had this really big ring on her finger. And I said, "Wow, that's a really pretty ring. Where did you get that?" And she goes, "Oh, it's my Ambien ring." And I said, "It's your Ambien ring?" She said, "Yeah, I bought it in the middle of the night, and I didn't even know I bought it until it came in the mail for me." So, that's that. And then obviously I said, "Well, now that you've said that to me, we have to start weaning you off of this medication." I've also got a friend who's a police officer in Houston, and he says that he'll often stop people like in the middle of the night, and he always knows when it's an Ambien driver, because they'll be driving and they're on Ambien and they're not drunk, but they're totally spaced. Their recall's really bad, but they can pass the test for somebody who's inebriated, but they're just kind of like glassy-eyed. They will not recall that. So these medications, the sedative hypnotics, Ambien, Lunesta, Sonata, those medications, they can be dangerous, and so you want to be judicious when you prescribe those medications. That FDA warning about Ambien, where we are decreasing the amount for women to 5 milligrams and then over the age of 65, and it's because people are impaired even if they don't feel impaired. So if I have to give somebody a sleep aid for a sleep study, I make them actually get a ride home the next morning, because even if you don't feel like you're impaired, you may very well be impaired using these medications and not know it. So kind of on the horizon, there's a lot here in terms of helping that patient with compliance. I know I talked about a lot of different things today, tried to kind of give you a big nutshell of everything in a nutshell on sleep medicine, but there is a task force with physicians from the Oregon Clinic, Providence DME, trying to figure out how best to help patients in terms of making this more of a streamlined process, making people feel comfortable, and increasing compliance with sleep apnea. So it's in its infancy, but the goal is that we increase compliance for patients, and that patients feel more confident about using their appliance and their CPAP machine, and that, as one lady told me, that was the best birth control I ever gave her. That they don't see it like it's a barrier to their life, because it really just is air. And then if anybody is interested in lunchtime sessions, any of us who are practicing sleep medicine at the Oregon Clinic, we're happy to come and talk with you about like the differences between home sleep tests and in-lab polysomnograms, CPAP compliance strategies, how to kind of help a patient who's struggling with their CPAP, more on circadian rhythm disorders, movement disorders, and then just, on how we tackle those patients with insomnia. And then if anybody is really interested in sleep and kind of being the champion or the expert in their clinic, there is a Providence Sleep Symposium that's happening October 26th, and it's from 11 to 8 because we do have sleep technicians that come to the conference, and they're the ones who are working at night. They're the ones who have the shift work disorders, who are coming at night, who are coming and to the conference during the day. So I think that's it for me. Does anybody have questions? Yeah?
Would you please comment on surgical treatment for sleep apnea?
Surgical treatments? I don't, and really briefly, I don't really think that they work. So patients often will have that UPPP. I don't know how many patients I've seen who've gone through that surgery. It's a big deal, and it doesn't work long term. They end up needing to use a CPAP machine later on. But for the mandibular advancement, that actually, so some patients will have kind of that retrognathia or micrognathia. They'll have an abnormality in their jaw. And actually that surgery can be successful for people who have mild or even moderate sleep apnea. When you have severe apnea, all bets are off sometimes. You know, I had one patient who really wanted to get that surgery done, but their apnea-hypopnea index was 60. And, you know, it's kind of a balancing act then, you know, because it's a lot of time, and it's a big surgery, and you may end up still needing to use a CPAP machine.
Is there any rationale for taking some melatonin after awakening at 2 or 3 compared to earlier?
You know, there's not a lot of evidence around that. I did do some research, but, oh, I'm sorry, yeah. So your question was, is there any rationale for using melatonin when you wake up in the middle of the night? You know, what I usually tell patients is if they've been using it and it works, stick with it. But I don't typically have patients use melatonin in the middle of the night, because then it can give you that hangover effect in the morning. Because if you're waking up like at 3 in the morning and you take this little dose of melatonin, you may end up having sleepiness during your daytime. There is anecdotally some, I've had people who use the quick dissolving melatonin in the middle of the night, and that may work a little bit better, and they might have less daytime symptoms with that. How do I prescribe light therapy? So typically, so for a person who's got delayed sleep phase, let's say that their internal clock wants to go to bed at 1 and wake up at 9, but they have to get up at 6 and go to bed at 10. So when they wake up at 6 o'clock, within about 30 minutes, I generally will have them sit next to a light, and the studies show that it's 10 to 12 inches away from you. You do not have to look directly into the light, and it should be 10,000 lux. So just for reference, the sun is 50,000 lux, and these medical grade lamps or lights are 10,000. And I actually have a handout. I'm happy to send that to whoever wants it, on some of the local companies who sell those medical grade lights, and then kind of a checklist or criteria for what you're looking for, because I know Costco sells those happy lights, but they're 5,000 to 6,500 lux. So then you have to increase your time if you're going to spend time in front of that light, because it's not as strong. So I have them sit there, and they can be reading the paper, eating, doing their work already. They can, you know, wait to go to work if they have to, and have it on while they're sitting at their computer. But you want to at least be in front of it for about 30 minutes.
Hi, that was great. I just am remembering the patients who were not totally forthcoming about using uppers during the day, amphetamines of one kind or another, and then trying to compensate with some sedative at night. And that got me thinking, the patients we've seen are totally zoned out on these high potency marijuana products that are available. Did marijuana play a role in any of your patients so far, especially the high potency variety?
Not so far, and there are some studies out there that say that it actually helps with sleep, but there isn't enough data out there that says one way or another. But you're right, you did touch on something that I failed to put in the presentation, which is a lot of times people who have daytime sleepiness will be given stimulants. And before you hand out stimulants, or prescribe, not hand out, because I also gave stimulants as a primary care doc for several years. Before you prescribe stimulants, you also want to make sure that you're treating, that you've evaluated for all these other things. Do they have delayed sleep phase? Do they have untreated sleep apnea? Is their sleep hygiene crap? And then, but still, you know, but I have to be awake, and then you give them stimulants. So, you know, that's what we're here for. That's what I'm here for, is to help you figure that out for the patient.
You mentioned it's all, the fact that a good proportion of the Latin world has a siesta. How does that fit in with your...
Yeah, so the question was that other parts of the world will have these siestas. They'll have that little nap in the middle of the day. They often will have later sleep times too. And I haven't actually read any articles about how that affects their sleep, but just having visited those countries, people have this siesta. Everybody kind of shuts down in the middle of the day, but then they'll eat dinner later. They're up later generally, and they start their day later. So I think it's just kind of shifting naturally, and they condition themselves to that based on their environment. Anybody else? Any more questions?
Is more clinically significant catching these people, figuring out that they have sleep apnea, or barriers to compliance with treatment in their home?
So say that again.
So I'm trying to decide, is it more important for me to figure out who is suffering from sleep apnea, or should I spend my time thinking about helping my patients who have been diagnosed with sleep apnea to use their equipment? Obviously, both are important.
Yeah.
But I'm wondering, like, in the grand scheme of things, which is probably more helpful?
I don't know. So his question was whether or not I should focus my time trying to figure out who has sleep apnea and get that diagnosis made, or should I spend my time figuring out who's not using their CPAP machine and help them improve their compliance? That's tough. I don't have an answer for that.
First of all, so I'd say get them figured out, and then you can go from there.
Okay, there's your answer. Okay, last question.
So some people have sleep apnea when they sleep supine, but when they are prone, they don't snore and don't have daytime sleepiness. A friend of mine went through the whole system down at Stanford, but she had never had daytime sleepiness, and she never slept other than prone. How do you pick up those people who really have positional sleep apnea, and how do you treat them differently?
So that is difficult, because if they don't have a lot of daytime symptoms, it's for me, I find that it takes a little bit more questioning and figuring out if they have fragmented sleep, because inevitably people will say, well, I always sleep on my side. But then as soon as they go to sleep and they're unconscious, all bets are off, and then they're moving around all over the place. So I'll ask more questions about any nighttime awakenings, or potentially softer signs. So maybe somebody will say, oh, I used to do this 10 years ago, or I was this level of functioning, but they don't realize that they've changed in their level of functioning over the last 10 years. And then the other piece is, sometimes we will see that on a sleep study, positional apnea. And that's an option for people, is to sleep in one position over the other, because there are a few people out there where they've got bad apnea when they're on their back, but when they're on their side or they're prone, they don't have sleep apnea. That's harder though, because generally you want to make sure, how do you make sure that somebody isn't going to flip onto their back when they're sleeping? So there are these devices that you can put on your body. There's called the REM. There's one called the REM-Mate. There's the Zoma pillow. They're not usually covered by insurance. They're anywhere between on Amazon. I think the Zoma pillow is $108. But they can go up to a couple $100, and then you got to wear that thing every night. And so it's the same. It's another trade-off. Like, do I wear this thing or do I wear this thing? What is it that I wear, and not worry about what position I'm sleeping in. All right. Well, thanks.